plasticized female body with the fetus in the uterus, prepared by Professor Higgins of Germany. Now, I just want to correlate two exceptional geniuses. One is Leonardo da Vinci and the other is Professor Higgins, who was who brought in plasticization of human bodies and animals. I just wanted to, you would like the picture, I feel, and just to give you the first slide. Now, shape of the uterus is a hollow, pear-shaped with thick muscular walls. Hollow, pear-shaped with thick muscular walls. Now, position and location, the bladder in the front and the rectum posteriorly. Within the broad ligament, lower end forms an approx right angle with the vagina, an angle of anteversion. This is important. You might get a short 4 marks to short note. Anteversion, anteflexion, and retroverted uterus. Okay. Now, size of the uterus in young nulliparous woman, its measurement is 8 centimeters long, 5 centimeters wide, 2 centimeters thick. You have to know the normal size, because this organ is a mysterious organ, because many tumors, fibroids and things that can be 13 kilos, 5 kilos, 2 kilos weight, and a small uterus of normal size or just a bigger size can have abnormal uterine bleeding very much, but a 13 kilo tumor or 10 kgs or 5 kgs uterus does not bleed at all. Scanty bleeding. So, now parts and relation. Fundus, convex, related to the coils of small intestine, directed anteriorly and superiorly. Body, vesical surface lies on the superior surface of the bladder and covered with peritoneum, which is reflected onto the bladder, forming uterovesical pouch. Intestinal surface related to the sigmoid colon and coils of small intestine covered with peritoneum. Lateral margins receive uterine tubes, uterine vessels by the side, and related to the broad ligament, mesometrium, round ligament and ligament of ovary. Cavity of the body is triangular and coronal section, but cleft in the sagittal section, merely a cleft in the sagittal section. Now, parts and relation. The isthmus, constituted part of the uterus, 1 centimeter in length, and cavity called internal os. The cervix extends downwards and backwards from the isthmus and pierces the anterior wall of the vagina, divided into supravaginal and vaginal parts. Supravaginal part anteriorly, the bladder, posteriorly coils of small intestine, laterally uterine artery and ureter embedded in the parametrium. Vaginal part protrudes into the vagina, forms vaginal fornix. The cavity of the cervix, the cervical canal, is spindle-shaped and communicates with the cavity of the body through the internal os and with the vagina through the external os. Now, peritoneum, from middle 1/3 of the rectum, the peritoneum reflected on the posterior surface of the upper part of the vagina. Rectouterine pouch, pouch of Douglas, continues over intestinal surface of the uterus body and passes around the fundus. Continues down over the vesical surface, of the body and at level of fornix, anterior of the vagina and peritoneum reflected onto the posterior surface of the bladder. Now, this is the peritoneal reflection because all organs of the abdomen are extraperitoneal. Okay. Now, blood supply of the uterus, the uterine artery, branch of the internal iliac artery. Second, the ovarian artery, branch of the aorta rising from the L1 level. Now, venous drainage of the uterus, venous plexus drains through the uterine, ovarian and vaginal veins into the internal iliac vein. Lymphatics, drainage of the uterus, fundus into the para-aortic nodes, body of the cervix into the internal and external iliac nodes. This is important. Body and cervix into the internal and external iliac nodes. Note a few lymph nodes also drain into the superficial inguinal lymph nodes. Now any lady is presenting with you, she might be saying that, see, I have some swelling over here. With a foul discharge, then you have to do a pervaginal examination and see the cervix, and you do a speculum inspection. Cusco's or duckbill's speculum. Now, this is the duckbill. It is like this. The lower figure, that's the handle, and there's a thing, liver, that goes up like this. It widens and opens. Now, this is it's open. Now, you put in like this and just put it up. You view the external os, the cervix, and you have to look for any growth, any polyp, any cyst. Cyst, you can feel it. If it is oversized, Nabatean glands, they become cyst. This is very important. Most of the gynecologists who are in a hurry, practicing from Durgapur to Nanur, they don't do a speculum examination. 99% of the gynecologists are not doing a speculum examination. With record, I am telling you. But this is a very essential step. You might have 50 patients or 25 patients or one patient. You do any abnormal white discharge, any abnormal foul smelling discharge, any mucus with blood stain, যেটা আমরা বাংলায় বলি, that মাছ ধোয়ার জলের মতো কি আমাদের রুরাল আরবান পেশেন্ট, যে আপনার কি ডিসচার্জটা মাছ ধোয়া জলের মতো আসছে বা মাংস দেওয়ার জলের মতো আসছে? Just you please view, because it might be so that a small polyp is there, size of a almond or date, and you keep on giving for abnormal uterine bleeding, you go and giving your hormones. But she comes and complains, sir, I'm not well. But if you see such a relation, then you advise a biopsy of that polyp. It's simple outdoor procedure, and send it for histopathological examination, and you will be getting the result accordingly. And then also you advise, definitely you will advise an ultrasonography USG of the pelvic organs with transvaginal examination with the probe TVS when you order an USG. Especially you having complaint or no complaint, means she comes with a complaint, but even you see with a speculum, you might not find a polyp, you might not find a growth, but you do a TVS examination. When you do for pregnancy, and the lady comes and tells you that 2 months I have a urine test, I have done a kit test, and there are 2 lines. If she is having any woman, it can be just the first pregnancy or it can be third pregnancy, but you do a pelvic ultrasound and also TVS, because it might be ectopic pregnancy. So if there is an ectopic, you will be misled. Then if there is an ectopic, then you have to do surgery. You just can't do dilatation, curettage and evacuation, D and CE. If you do that, you are just say 1.5 months or 2 months pregnancy, you are doing a curettage, MTP. Can you hear me? Okay. Hello? Hello? এমনি শুনতে পাচ্ছ? বাস ঠিক আছে। এবার কথা হচ্ছে, if you come out doing an MTP, but after 48 hours or so, she gets acute pain and gets admitted in the hospital. They do a rescan and transvaginal, they diagnose as an ectopic. Ectopic can be done, diagnosed also per abdomen by ultrasonography. So this is a very important thing you have to remember when you are and if there are any inguinal lymph nodes swollen, first thing, you don't think of cancer, but you have to see, you ask her, the external inguinal lymph nodes, you have to ask her if she had an abscess or some leg injury or any impetigo that drains into the inguinal lymph nodes. That can be first thought. Second thing, if a middle-aged lady, she comes with a foul discharge or something like that, then definitely you will inspect the cervix. And if you feel, now you see with the cusco speculum, and slowly, gently you have to enter, slowly. You just put it and just lift up, then she starts bleeding. You put your fingers Fingers are the best instruments. So you just see and see if there is a growth and this thing. Okay. Now, nerve supply of the uterus, uterovaginal portions of inferior hypogastric plexus supply from T12 to L1, parasympathetic supply from S2 to S4. Now, clinical notes, uterine examination by bimanual palpation. Now, the prolapse of uterus. Now, in prolapse, there is first degree, or this might be any lady with a normal delivery. Then there is a descent. The bladder can be seen, and also it can be a small part, a little bit of the rectum. So, cystocele, rectocele. Okay. Now, this is the normal position of the uterus. Anteverted extends forwards and upwards from upper end of the vagina at approximate right angle. Anteflexed, body bent downwards at its in the isthmus. This position is generally maintained by muscles, fibromuscular structures, facial condensation, ligaments, and possibly peritoneal folds. Now, this can be a question of 10 marks. Supports of the uterus. And now this is the position of anteversion. This is 90 degrees angle of anteversion. Here is the cervix, and anteflexion 170 degrees position of anteflexion. Now, important supports. Now, levator ani muscles, anterior fibers, pubovaginalis from the sling and support the vagina, indirectly support the uterus, and fibers are inserted into the perineal body. Note, if levator ani is torn during childbirth, support of the vagina is lost and it tends to sink into the vestibule along with the uterus. Prolapse. What is prolapse? What is the prolapse of uterus? You see, if levator ani is torn during childbirth, support of the vagina is lost and it tends to sink into the vestibule along with the uterus. Prolapse. The perineal body situated between the vagina and the rectum and stabilized by numerous muscles. Examples, superficial transversus perineum and external anal sphincter acts as anchor for levator ani and maintain integrity of the pelvic floor. Now, the urogenital diaphragm. Now, this can be a 2 marks question. The perineal body can be 2 marks question. Some fibers are attached to the vagina and help support both vagina and the uterus. Now, important supports, ligaments. These are condensation of pelvic fascia on upper surface of the levator ani muscles attached to the cervix and vagina, support uterus and keep cervix in proper position. Transverse cervical ligament, cardinal ligament, connected lateral aspects of the cervix and posterior upper vagina to lateral pelvic wall. Pubocervical, symphysis pubis to the cervix of the uterus and the posterior of surface of the pubis. Sacrocervical ligament, connected cervix and upper end of the vagina to lower end of the sacrum, forms 2 ridges, one on either side of the recto-uterine pouch and helps to maintain uterine access. Round ligament of the uterus, remnant of the lower 1/3 of the gubernaculum, connects lateral angle of the uterus to labia majora by the inguinal canal. Uterine access, anteverted position of the uterus prevents from sagging down the vagina. This access is maintained by the round ligament of the uterus and the sacrocervical ligament. The following are also possible supports: broad ligament, uterovesical fold of the peritoneum, recto-uterine fold of the peritoneum. Now, supports of the uterus can be a full question. Full question is 10 marks, or in your question paper you have seen the 1 + 2 + 3 like this. So, each part, component you draw some figures, some illustration, and go on labeling them. Now see, this is a picture. This is the sacrum. This is the cervix. This is the rectum. This is the urinary bladder. The pubocervical ligament. This is the pubis, symphysis pubis, and uterosacral ligament. This is sacrum. The simplified diagram, and this is the sacrum in sagittal section. S1, S2, S3. This is the cervix. This is the ligament. Uterosacral ligament you see, and the round ligament is here, and pubocervical ligament here, transverse cervical ligament here. So this is simplified diagram. All of the textbooks you are reading, it can be any Singh, it can be any Datta, it can be any Chaurasiya. You will get these figures. Okay? Now, clinical notes. Tear of the perineum may cause a prolapse of the uterus, also due to hard labor or weakness in any of the supports. Now, this is a picture of the uterus which is cut off, and you can see the vagina, myometrium, ovary, uterine tubes, endometrial cavity. This is the sagittal section. In our dissection hall, you have a beautiful this picture of the dead body specimen prepared by Dr. Shapun Bhattacharya. Okay. Similar picture. Now see, this is the ureter. You see the relation with the uterus. Now this is a laparoscopic view showing the round ligament. Here is the round ligament. These are the ovaries here, fallopian tubes, and the uterus is here. The broad ligament. This is the broad ligament. This is a laparoscopic view of the pelvic cavity and the pelvic organs of the female in a different aspect. You see the uterus showing the lateral relation with the laparoscope, the round ligament, the external iliac artery, here the external iliac artery, and this is the fimbria, uterine tube. Now, this is the bladder, urinary bladder. This is the balloon in the catheter. For any surgical maneuvers, for abdominal hysterectomy or the cesarean section, you put a balloon catheter, Hollis catheter. See, this is the two holes here, and now what to do? That is the measurement for each catheter, 16, 18, 20, and this is the This is the Euro bag. Euro bag. Okay. Urine passes through this. And this is the small valve-like thing, a rubber. You inject 10 ml of distilled water first, and then according to the condition it can be 15 ml, but 10 ml is sufficient. 15 ml to the balloon swells up. The balloon swells up like this. Now, this is the urethral opening. See, this is the urethral opening. Now, if you pull, it does not come out. It is a self-retaining Foley's catheter. And that is the picture showing the balloon. Now, when you are viewing or assisting in the laparoscopic maneuver or operation, then the swelling is there. You might be telling your professor that, sir, there is a swelling there in the bladder. Don't be mistaken. Oh, you'll say, no, it's a bladder. What did you do? When you are means an intern or a house staff or a SR or junior, so when you are assisting, you will be preparing this patient. You have to put in the catheter, you have to put that patient in the table and then go to assist. But if you cannot tell what is that swelling, he might question you, you might not question him. But he can question, what is the swelling? He sees the screen. What is that swelling? Then you have to say there is a bladder, balloon of the bladder, a catheter. Now, this is this is the ostium, this is the fundus, right uterine tube. Now, this is a yatal section. Now, this is a picture from Grant's anatomy book. I like this picture because of its simplicity. This book, if I were in the upper level saying to have to say for the syllabus of book or anything by NMC, then I would say that Grant's anatomy book should be the book of you have to read. Anyway, you have to become an artist, you have to copy someone. It might be Leonardo da Vinci, it can be Rabindranath Tagore, it can be Picasso. So that is not wrong. Now you see the rounder simplicity. Tube, mesosalpinx, this is the ureter, related to the ureter. This is the uterine artery. Now, now this is a picture from an atlas, Netta's atlas. See, this is the fundus of the uterus, this is the ovary and the tubes, the anastomosis of the ovary and uterine vessels, mesosalpinx, broad ligament. See the relation. This is crucial. Then the ureter and the uterine artery. Now, during hysterectomy operation, removal of the uterus, you are assisting. So, you have to be sure that you are not clamping the ureter. That is important. That's why whenever I am doing an hysterectomy operation, I ask the OT sister that urine ta thik ache to? Is the urine not colored? Because it is in the below the OT table. So even when you send the patient to the ward, you measure the urine, how much. Don't depend on when you are a trainee. स्पेशली इंटर्नशिप, हाउसशिप, जान दे दो। 15 दिन ईएनटी होगा तो 15 दिन ईएनटी के लिए जान दे दो, 15 दिन डेंटिस्ट्री के लिए जान दे दो, 1 month for eye, 1 month for your ENT, whatever it is. You think that you are a gynecologist, you think you are an ENT consultant, think you are a dentist. So you have to be, this is to be, you have to be very cautious, and also that can be a small question. Now this is the picture, that previous picture. This is the supports of the uterus and the condition. Now this is a normal uterus, and see fundus of the uterus, uterine cavity, ovary, body of the uterus, uterine tube, cervix, external os, vagina. Now double uterus and double vagina, uterus didelphus, that is bicornuate uterus or double uterus with the vaginal. So a mother with a double uterus can conceive 2 babies in 2 uterine cavities. There are possibilities and it happens. Okay, it is not that it is very, it is a very rare condition, but now double uterus with single vagina, because after intercourse some millions of sperm, or if we oligospermia, there can be 10 sperm count. So 2 of the bold and this thing, they can fight and go inside in 2 cavities, and that can lead to a pregnancy. Now bicornuate uterus, double uterus, this can be diagnosed with your USG, but if a patient comes with sterility, then you do an USG and do a hysterosalpingography. That is a dye pushed into the uterine cavity to see if there is any blockage in the tubes or any abnormal mass is there or something like that, or the uterine cavity is not having much space. That can be seen by hysterosalpingography. Now bicornuate uterus with rudimentary horn. See, rudimentary horn. Now septate uterus, this is the septum dividing the uterine cavity. Now unicornate uterus, now this is the uterine arteries. The uterine artery, in 90% cases, 4% is in this form. 90% is this form. This is the ovarian artery. This is a picture from the Netter's Atlas. These histological features are endometrium. This is the MRI of the pelvis. Here's the MRI of the uterus. Now, location of uterine fallopian tubes, upper free border of the broad ligament, mesosalpinx. Now, extent of uterine tubes, 10 centimeters long, runs laterally from uterus to uterine end of the ovary, passes upwards on mesomeria border arches over the tubal end, terminates in the free border of the medial surface of the ovary, not joined by two over released in peritoneal cavity. Now parts of the uterine tube: infundibulum, ampulla, isthmus, intramural. The lateral expanded part of the abdomen ostium opening surrounded by finger-like fimbriae. One fimbriae is equal to ovarian fimbriae attached to the tubal pool of the ovary. Inner surface lined by ciliated columnar epithelium. Now, see the ovary is here. The over is now it is like funnel-like and ciliated. এই যে দুর্গাপুজোয় বড় একটা হাত পাকা থাকে না, বাতাস দেয়, তো similarly it tries to propel the ovum into the tube, and the ciliated is covered by ciliated epithelium, and blood supply of the fallopian tube. The medial 2/3 of the uterine artery, branch of the internal iliac, lateral 1/3 ovarian artery. Now venous drainage of the uterine tube, pampiniform plexus of the ovary and uterine veins. Lymph drainage, most drain into the lateral aortic and pre-aortic nodes, some around isthmus following round ligament of the uterus into the superficial inguinal nodes. Nerve supply T10 to L2 by inferior hypogastric plexus, parasympathetic mainly from pelvic flanking nerves S1, S4 by the inferior hypogastric plexus. Clinical notes. Now tubal pregnancy, common ectopic pregnancy, sterility caused by blockage of tube due to inflammation, female sterilization by tubectomy, ligated and excised. Now hysterosalpingography, say a lady, she gave birth to 2 children. Now after at 3 and second child, she goes for a tubectomy and ligation. Again the second child died. Then they try to come and say recanalization. Recanalization, that time you have to do a hysterosalpingography and see how much blockage, how much the extent of the tube, and accordingly plan, but there won't be any spillage of the dye into the pelvic cavity. So accordingly, under microscope, of course, people are doing these operations, but you have to discuss, consult, that you cannot give 100% surety, or that but you can take a chance. Now size and shape of the ovary, it is diamond shaped, dimension 3 into 2 into 1 centimeters. Position and orientation is located in the ovarian fossa on the lateral wall of the pelvis behind the broad ligament, attached to the back of the broad ligament by mesometrium. Nulliparous woman, its long axis is vertical. In multiparous woman, upper pole laterally and lower pole medially. Parts of the ovary, it has a lateral and medial surface, and upper tubal and lower uterine poles, anterior, mesoovarian and posterior free border. The relations of the ovary: anteriorly obliterated umbilical artery, posteriorly ureter, internal iliac artery. The obturator nerve crosses floor of the ovarian fossa, and posterior laterally fimbriae of the infundibulum of the fallopian tube. Now suspensory ligament of the ovary, round ligament of the ovary, and the mesoovarium. Blood supply of the ovary, the ovarian artery branch of the aorta level 1 descends in the suspensory ligament to the broad ligament, sends branches to the ovary and the uterine tubes, and associates with the uterine artery. Now, venous drainage, pemphidiform plexus, ovarian vein, right side into inferior vena cava, left side into the left renal vein. This is important. It can be a MCQ question or you can ask in Viva. Now, nerve supply of the ovary, ovarian plexus derived from the renal, aortic and hypogastric plexus, accompany ovarian artery, contains sympathetic nerve T1, T10 to 11, parasympathetic nerve S2, S3, S4. Thus, pain is referred to inguinal and vulval regions. Now, lymphatic drainage, pre-aortic nodes and para-aortic nodes. Clinical notes: before puberty, ovary is smooth and grayish. After puberty, it is puckered and turns grey. When old, it may be shriveled. Ovarian cyst, ovarian carcinomas, prolapse of the ovaries into the recto-uterine pouch. Now, this is the picture of the laparoscopic picture. Now, this is the ovary, and this is the femoral end of the tube, small bowel, sigmoid loop. Now, you see, this is the uterine tube, this is the ovary here. The histology of the ovary. Now, this is the histosalpingography of picture of the uterus and the fallopian tubes. Now, clinical manifestation of the uterus, ovary, fallopian tube. Now, prolapse of the uterus. This is the prolapse of the uterus. Okay. This is the clitoris, bladder. This is cervix. See, it's prolapsed so much. And this is the polyp. People, women. These pictures are from my clinic, which I had operated on. But you see the devastating picture. Still now you will get. And the woman is neglected very much. Okay. Now, huge uterine fibroid. Yeah, fibroid. Now, this is the ovarian cyst. Huge ovarian cyst, fibroid. This is a ovarian carcinoma. When no ultrasound was there, no modern imaging was there, we used to explore with a big lump. So, exploratory laparotomy, as if we are exploring going to North Pole, South Pole, or Everest from Nepal side. It was that. But we had to give relief to the patient. Naturally, now this is the picture of hydrosalpinx of the tube. See the swelling, the femoral end, hydrosalpinx. This is the ovary, this is the ovary. Now this is the huge ovarian cyst and uterine fibroid. Now, this is one thing I would say is a very rare condition. I had presented the paper in the national conference of, now, when you go to hematology, you see two Mullerian ducts. Now, these two unite and they form Okay. Now a single Mullerian duct, two Mullerian ducts. Now I'll just show you. This is a Rotnitsky syndrome, and you see this is the Mullerian fallopian tube in the. Now next picture. See the fundus of the future fundus of the uterus for the two Mullerian ducts here, one, and two ovaries are here. She came with a complaint of she's not having menses, and she was sterile. No USG was done in those days, around in the 80s. Now, uterus from single Mullerian duct. Now, I showed you earlier the sketches. Now, the single, but that led to a uterus. See the full uterus. She was pregnant. I delivered by LUCS. So, but you see, what I used to do, see, this is one of the, she's without gloves. But I was in a hurry. What I used to do is that I had a table with 6 pairs of gloves or 8 pairs and the camera in one table. And open, see what is there, and I find anything, I tell my assistant, you please hold it. I should change the gloves, take the camera and shoot. There was no digital photography, no mobile, nothing. And you please, when you are a student, medical student, when you are seeing the dead body, when you are seeing the vertebra, when you are studying osteology, if you find any abnormal, you please take up, you have an advantage. You take a photograph, keep it. Like this, I have some 1,000 photographs in my archives. More than 1,000.